Καλησπέρα και από μένα. Θα ήθελα να ευχαριστήσω την Οργανωτική Επιτροπή και τον κύριο Κότσι για την πρόσκληση και να σας κάνω να ζηλέψετε γιατί το μέρος αυτό είναι υπέροχο και χάνετε που δεν ήρθατε, εκείνοι που είστε μακριά. My presentation is going to be about obstructive sleep apnea syndrome and the long-term effect of continuous positive airway pressure on blood pressure of patients with resistant hypertension. And I know that all of us here, I'm sorry for the delay, but we're all of us here are not sleep doctors or pulmonologists, so I'm going to tell you what obstructive sleep apnea is. It's the most common sleep-related breathing disorder, and it involves the complete or partial obstruction of the upper airway in an ongoing effort to breathe. And the severity of sleep apnea is defined according to the number of apneas and hypopneas per hour of sleep. And it is defined as mild, moderate, and severe, as you can see. So we all know that diurnal variation in blood pressure, heart rate, and cardiac events occur during normal sleep. And you can see that in non-REM sleep, there is a reduction of sympathetic activity and an augmentation of parasympathetic activity. So blood pressure, heart rate, cardiac output, ventilation, and metabolic rate are reduced. On the other hand, during REM sleep, sympathetic activity is increased, so blood pressure and heart rate are increased. And if someone is suffering from obstructive sleep apnea, he doesn't have a very normal sleep. So this is interrupted, and this normal sleep and heart interaction is really disrupted. And sleep apnea is not a very rare disease. And as you can see here in this map, it's really frequent all over the world. So we have to face this disease, and pathologists and cardiologists also have to deal with that, because obstructive sleep apnea is a highly relevant disease to patients with hypertension, and especially in patients with resistant hypertension. It is the most prevalent secondary contributor to elevated blood pressure in these patients. And as you can see in this slide, the more severe the disease, the higher the incidence of hypertension. So we should keep that in mind for our patients. In this study, you can see the clinical characteristics of the patients with resistant hypertension. And you can see that one of the most prevalent is obstructive sleep apnea, and next is metabolic syndrome. So we should really keep this disease in mind when we have to deal with these patients. On the other hand, the prevalence of sleep apnea in these patients is really high. You can see that almost 84% of the patients with resistant hypertension suffer from sleep apnea. And the more severe the disease, the higher the blood pressure, and especially during the night. And again, we should keep that in mind, because this especially this figure shows that there is a dose response association between sleep apnea severity and blood pressure measurements, and especially during the night. What is the covariates that are associated with the presence of sleep apnea in these patients? You can see that older age, you can easily imagine a male sex, obesity are contributors, and of course the nighttime augmentation of blood pressure. So we should check our patients with resistant hypertension for sleep apnea if they all suffer from these. In this recent paper, you can see the title that obstructive sleep apnea is more severe in men, but not women, with refractory hypertension compared to controlled resistant hypertension. However, I would check all the patients with refractory hypertension for sleep apnea, independent of their gender. So in this figure, you can see the mechanism that are linking these two diseases, obstructive sleep apnea and hypertension. And as we know, obstructive sleep apnea causes recurrent episode of hypoxemia, intermittent hypoxia, hypercapnia, and negative intrathoracic pressure during the events, and also sleep disruption. And all these lead to increased oxidative stress, metabolic dysregulation, sympathetic activity, and also systemic inflammation. And all these have an impact in vascular remodeling, endothelial dysfunction, and atherosclerosis. And also, as I will show you afterwards, hyperaldosteronism is a very common disease. In this very recent paper, it was found that primary aldosteronism is very highly prevalent in patients with hypertension and moderate to severe sleep apnea. So I would always check according to this very recent paper for this disease in patients with resistant hypertension and sleep apnea. What about treatment? The gold standard of treatment of sleep apnea is continuous positive airway pressure. And what is continuous positive air pressure? That is CPAP. It's a device that provides a steady stream of pressurized air in order to keep the airway open and prevent these pauses of breathing. So could this device help and be an effective and practical antihypertensive agent, especially for patients with resistant hypertension? In this older paper, but very, very important, you can see that the long-term effect of CPAP in blood pressure in patients with sleep apnea is modest. You can see here that the reduction of blood pressure is about 2 millimeters of mercury. However, when patients are using their device and they're compliant to the device, they wear more than 5 hours, the reduction is greater. So the conclusion is that okay, the CPAP maybe reduces modestly blood pressure. However, if someone has a good compliance, there is a significant reduction of blood pressure, and even a small reduction, we know that is very important for the cardiovascular outcome. This is a meta-analysis about on studies about resistant hypertension, and again you can see that there is a reduction about 5 to 3 millimeters. Here you can see the studies on resistant hypertension, and most of them concluded what I told you before, that the reduction exists, but it's not as big, as important as if someone received antihypertensive therapy. However, the thought of combining CPAP and antihypertensive drugs is really, really important. We should keep that in mind. This is the PARCO randomized clinical trial, but it's the most famous study on the effect of CPAP on blood pressure in patients with sleep apnea and resistant hypertension. And again, you can see here that there is a reduction of blood pressure, and this reduction is more important in patients that are non-dippers. This is the post hoc analysis of this study, and it seems that continuous positive airway pressure helps and has a better effect in patients with refractory hypertension compared to those with resistant hypertension. And this is a very recent analysis of the long-term effects of CPAP on the cardiovascular events in these patients. And the follow-up of the patients were about 58 months. And here you can see that the hypertensive crises are less in those patients who are using the device more than 4 hours. However, you can see that the number of patients is really low. It's only 8. And here you can see that the hazard ratio of having a hypertensive crisis, if you're not wearing the device, is about 5.9. However, we should think about the predictors of the fall of blood pressure in these patients. And it seems in older studies that the baseline blood pressure, the change of Epworth Sleepiness Scale, that is sleepiness, and also the baseline BMI are really important for us to predict if the blood pressure will fall. And this is a more recent study that that evaluated which phenotypes predict the response of the reduction of blood pressure. And it seems that those patients who have resistant hypertension, those who are aged less than 60 years, who have uncontrolled blood pressure at baseline, and also they have severe oxygen desaturation, are those who would have the better effect of the device. In this study, I know that there are very small letters, they found that the effect of CPAP compared to some CPAP, that means a device that doesn't really work, for 3 months was important in blood pressure. You can see here in pink. However, there were no effect on metabolic factors, and we should also keep that in mind. So we should also keep in mind that the treatment with CPAP, it's a bit difficult, and almost 35% of our patients are compliant with the device. However, we should also keep in mind that around 35% of patients with hypertension are not really compliant with their entire regimen. So we come back to that I told you before, that probably a combination of CPAP with medication should reduce the cardiovascular diseases better. And this is a study that shows this effect. This is the effect of valsartan on blood pressure. And okay, it's better than the CPAP, but when we combine both treatments, the effect is even better on reduction of blood pressure. My presentation was about the long-term effects of CPAP. And in this study, the patients were followed for a median of, you see, 57 months. And you can see that most of them were compliant to the device. They used more than 4 hours, almost 75% of the patients, and 45% used it at least for 6 hours per night. It's excellent compliance. And the difference between those patients that used it and not, the most important comorbidity was the previous stroke. If someone had a previous stroke, they didn't really use the device. However, something that the doctors that we work with patients with sleep apnea really know is that the good adherence within the first month of treatment is really important. And in this study, you can see that the good adherence and the long term was really associated with the good adherence during the first month. So we should really solve all the problems with the device really soon. So to conclude, as I told you, CPAP adherence is very strongly linked to the better results in the long-term follow-up, and the reduction of blood pressure is really correlated with that. However, we need more studies in including patients with good compliance and not very good compliance. Also, it's really important to include different sleep apnea phenotypes, because all the patients with sleep apnea are not the same, and there are subtypes of sleep apnea patients that are sleepy, or others that are not sleepy, and we know that the compliance is better in those who are sleepy. And also there is the hypoxemic features that it seems that patients have a better effect on their blood pressure. So it's really important to design studies on these particular types of patients. Thank you for your patience, and sorry for the problems.